morning. I'm excited to be presenting to this group, which I consider legendary. I have no disclosures. Today I'm going to talk about venous thromboembolism, VTE, which includes both deep venous thrombosis, DVT, and pulmonary embolism, or PE. There are multiple medical societies who have advocated aggressive VTE prophylaxis, and the most commonly quoted are the American College of Chest Physicians and the National Comprehensive Cancer Network guidelines. For inpatients undergoing abdominal pelvic or thoracic surgery, or inpatients with a cancer diagnosis, VTE chemoprophylaxis with or without mechanical is recommended. Furthermore, based on randomized controlled trials performed over a decade ago, they recommend post-discharge chemoprophylaxis for patients undergoing cancer surgery. Both recommend low molecular weight heparin, 40 milligrams daily for 4 weeks. These guidelines are now standard of care for high-risk GI surgery. In our review of the NISQIP database, we found a 5% overall VTE rate for esophagectomy, with 17% occurring after discharge. So we have actually identified a hole in the literature. An esophagectomy is a 2 to 3 field procedure involving at least the abdomen and the thorax, and there are well-documented high risk of VTE after esophagectomy. Yet there are no specific VTE guidelines for esophagectomy, so we sought to characterize the problem. Therefore, the aims of the current study are to investigate dedicated general thoracic surgeons' practice patterns for VTE chemoprophylaxis and esophagectomy patients, and to investigate their opinions toward VTE chemoprophylaxis. We distributed a 30-question online survey to the active members of the General Thoracic Surgical Club with a 30% response rate. The first thing that we found was tremendous variation in drug choice, dosing, and timing of administration of VTE prophylaxis. 60% utilized heparin every 8 hours or low molecular weight heparin, 40 milligrams daily, which is considered best practices for high-risk patients. What is most striking is that 30% are using heparin Q12 hours, which is a dose that is increasingly felt to be suboptimal. While the NCCN states that all of these are acceptable methods of VTE prophylaxis, several studies suggest that heparin Q12 hours is insufficient. Initiation varied as well. Only 53% of surgeons start in pre-op. 1/3 did not begin until the day after surgery. Yet 87% agree that prophylaxis does not increase the risk of bleeding. The majority of thoracic surgeons estimated a high risk of VTE after esophagectomy. 5% is what we found in our NISQIP data. But an important 30% did not consider esophagectomy to be high risk for VTE. Acute pain services managing epidurals after an esophagectomy restrict chemoprophylaxis choices. Heparin Q12 hours was by far the most commonly permitted prophylaxis. Of note, only 27% of pain teams allow low molecular weight heparin, 40 milligrams, Q24 hours, despite their own National Society guidelines allowing it. Again, post-discharge VTE prophylaxis is recommended for cancer surgery, yet only 13% of surgeons discharge patients on VTE prophylaxis. There were no difference in respondents in number of years in practice, type of practice, or practice location. Furthermore, the annual number of esophagectomies performed by the surgeon and routine use of epidurals were not associated with use of post-discharge prophylaxis. The only significant difference was that those who self-identified as minimally invasive surgeons were more likely to discharge a patient home on VTE prophylaxis. So in summary, practice patterns vary widely for post-esophagectomy VTE prophylaxis. A minority, 13%, of patients receive post-discharge VTE prophylaxis. Minimally invasive surgeons are more likely to discharge patients on prophylaxis, and dedicated general thoracic surgeons agree to follow evidence-based guidelines to improve post-esophagectomy morbidity and mortality. In conclusion, general thoracic surgeons are aware of the high risk of VTE in esophagectomy patients. Variation exists in drug choice, dosing, duration for inpatients and post-discharge prophylaxis. And dedicated general thoracic surgeons recognize the need for consensus recommendations for VTE chemoprophylaxis. Thank you.